Okay, so I am delighted to welcome you to Reframing Wellness, the transition from individual to organizational well-being. And this is a AAAEM sponsored session. And this session is, well, let me just say this. The line, "You cannot yoga yourself into wellness," is brilliant. And I will end the introduction of what this is all about right there. Introduce our speakers, Rita Manfredi and Arlene Chung, who are going to give you their own background, and we'll get rolling. Just a little housekeeping. If you can hold your question or put your questions in the chat, we will respond to them after the lectures or after the didactic is done. From that point on, Rita, take it away.
Hi, I'm Rita Manfredi from George Washington University on faculty there. And yes, you said it. You can't meditate your way into wellness anymore. The research shows you can't yoga your way into wellness either. It's the system that's breaking and burning out our emergency physicians. So we want to tell you about the exemplary strategies that some institutions and departments have utilized. But I'd first like my co-presenter to introduce herself.
Hi, everyone. My name is Arlene Chung. I am the program director at Maimonides Medical Center in my day job. In my not so day job, I guess I hang out with Rita once upon a time in person and now virtually, scheming up ways to make the world a better place, I suppose. So our goal is to share some of, I guess, some advice that maybe you can take home and suggest to your own institutional leadership as far as how we can maybe address some of the challenges that we've all faced over the past year and going forward as well.
So, oh, I'm stuck. Hold on, let me see if I can get the slides to move forward. I'm going to unshare them just for a second and then share them again to see if I can get them unstuck. Okay.
That's working.
We have no disclosures, but we do have some objectives. And those objectives are telling you about the gaps in knowledge, some guidelines for institutional policies, and some exemplary strategies that departments have done. But you know what? These are objectives, but what I really want to tell you about are Herb Kelleher's objectives. Now, let me tell you a story. Herb Kelleher in 1981 became Southwest Airlines president and CEO. Okay. And you know, Southwest is one of the most successful airlines because of Herb Kelleher's objectives. He insisted that employees should come first and that the customer is not always right. So, empowered by the knowledge that their boss had their back, employees would treat customers really well. And those satisfied customers, in turn, would become repeat customers, which would make the airline successful. And you know how successful it is today if you've ever flown on Southwest. So let's take that and put that in doctor terms. Clinicians come first, and if they are treated well by the organization, then they will excel at providing exceptional care for patients. And those patients will be satisfied patients. So what results is a really successful practice with professionally fulfilled clinicians and very satisfied patients. So who cares about well-being? Well, right now, because of COVID, it seems like only the clinicians working in the trenches care about well-being. But you know what? We're starting to see a slight glimmer of understanding from those at the leadership positions in our organizations and institutions. So we know COVID has affected our well-being. We all feel it. So pre-COVID, what were we talking about? Well, we were talking about, yes, you guessed it, aluminum foil. Three questions used by Alcoa, the world's sixth largest aluminum producer and one of the safest organizations in the world, expects their workers to answer affirmatively every day they work those three questions you see on the screen. Am I treated with dignity and respect every day? Do I have what I need so that I can make a contribution that gives meaning to my life? And am I recognized and thanked for what I do? Arlene, can you imagine if your chair walked through your department every day and asked you to answer these 3 questions affirmatively?
I mean, I would have to ask myself, like, what kind of workplace is this? Because I've never been at a workplace where someone did that to me. Maybe I'm working at Alcoa.
It's amazing, isn't it?
It's interesting. It's not just me, right? And I am one among many, right? The latest U.S. Census data actually tells us that there are approximately 900,000 actively practicing physicians in the U.S. These days. Unfortunately, the research that has come out from Tate Chanefeld and his colleagues, who that particular group has done a tremendous body of work looking at the prevalence of burnout in the medical field, has found that just about 500,000 of them suffer from burnout, right? And this is as measured by the Maslach burnout inventory. The range, sort of varies anywhere from say 25% to 75%, depending on the specialty. But unfortunately, as most of us are aware, emergency medicine tends to top the list, whether you're looking at the results from 2012, 2013, 2014, 2017, 2020, but hopefully not too much going forward. Now, burnout is one thing, but I think maybe one of the more important questions that we should be asking ourselves is, not just what is the effect of COVID, what is the effect of the pandemic on burnout, but what is the effect on physician suicide? Prior to the pandemic, what we knew or what we suspected was that there are approximately 400 doctors every year that die by suicide, and this number is likely underrepresented or underreported due to a variety of different reasons, both sort of social as well as legal, as well as medical. But I think, again, the thing that we need to remember, and this is a systems-based talk, is that, this is not just about doctors, right? And it's not just about doctors and doctors' friends and doctors' families, doctors' colleagues, right? So if we assume that each one of these physicians who died would have worked on average about 240 days in any given calendar year, and on each one of those days would have cared for, say, 20 patients a day, then this means that it's not just 400 doctors that are affected, right? We're looking at something like 1,920,000 patients that are affected by physician suicide, right? This is not just a doctor problem. This is an everybody problem.
You are so right, Arlene. So, what are we talking about now? It's still COVID. Well, I think COVID has been the great revealer, the great illuminator. It's really uncovered the weaknesses in our system. And I think everyone knows this. We've seen the safety of our patients compromised because of COVID. And remember, as David said, you can't yoga your way into wellness, and you can't meditate your way into wellness. Personal wellness is only a tiny part of the answer. So let's talk about this. Initially, research seemed to indicate that wellness and resilience could be obtained by your individual personal effort. All you had to do was be mindful, exercise, lose weight, stop smoking, do yoga, eat right, socialize, save your money, follow the spokes of that wellness wheel you see on the screen, and you will be well. But over the past few years, research has shown that's not the case at all. I'd like you to take a look at this very important conceptual model developed by the National Academy of Medicine. It's a conceptual model for clinician wellness and resilience. And a group of incredibly talented clinicians got together from all disciplines and constructed this model. So you can see patient well-being in the middle and clinician well-being almost right next to it depend on one another. And the surrounding 7 factors really determine our wellness. You can see that the individual or personal factors are blue, and there's 2 of them. And the yellow factors are the systemic factors, the organizational factors. So clearly and unmistakably, the system factors contribute the most to our well-being. So our focus now must be on the system with systemic changes at the departmental or organizational level and away from the individual. So we've really been approaching the problem from too narrow a perspective, and the focus has been on the individual to create wellness. And we have no idea how to do this at the departmental or system level. So we've got to think globally and really look at the big picture. Look at this picture. Arlene, do
Rita,
you
is
want to?
this a,
Yeah.
you still have this slide in here? This is like the random toilet slide. What is this? Why is this here?
Well, I hate to tell you this, Arlene and everybody. Do you know what this is? This is where I go for my own wellness in the emergency department. You know, it gets really crazy, but this is really one of the few places that I can go to where it's quiet. I can get my thoughts together. If something really tragic has happened, I can, figure it out. Let me go back to where we were. Sorry, let's get back to the toilet. And so what I think it's really tragic for any institution to have to impose that an emergency physician has to go into the bathroom to get a bit of wellness.
And I think this just really highlights problems that you, me, and everyone else in this audience understand on a daily basis. There are, we talk all these things, right? Like, we should be more well, and we need to focus on mitigating factors related to burnout. And this all sounds great in this like theoretical like Zoom room where we're living right now. But then some of us are going to shift later tonight or tomorrow or later this week or this weekend. And there's a number of different barriers, I think, that exist that get in the way of the best of intentions. And some of them are sort of very immediate, and some of them are not as obvious, right? And I think again, COVID was interesting because it highlighted so many different weaknesses in our system. PPE was like this huge factor related to our own well-being regarding like our own health and safety, the health and safety of our friends and our families and other people that we were interacting with. But it also made sort of, participating in that joy in work and that joy of caring for people difficult, because you're talking to your patients through this like mask, barriers and Tyvek suits and all of these things. And I think it took away a lot of that joy also. So not even just so much of the health and safety aspect, but really a lot of the joys that we were getting from direct patient care. Work overload, again, even in normal times, I think that there is like high acuity, high volumes, high stress in the emergency department, and certainly some stretched resources. And again, we only saw that getting worse during the pandemic. I don't know about you, we switched to a new EMR not too long ago, maybe, but I know, Rita, I see your face. I'm not gonna go into it here. This is not the platform, but let's just say that we are beholden to computers. And I don't think I think 2020 and 2021 has only highlighted that. And in fact, there have been studies that have highlighted just exactly how much time we're spending in front of computers. If you had to guess, Rita, do you remember what these numbers are?
Yes. Can I ask the audience? May I ask the audience? So audience, that's all of you out there. Do you have any idea what the average time an emergency physician spends in front out of an hour in front of their well, let's do it this way. Do you have any idea how long an emergency physician spends per hour with a patient in the ED, as opposed to spending it in front of their computer? Just throw some numbers out there. And Taylor's going to let us know some of the numbers in the chat box because I can't see it right now.
We have 20 minutes is the guess we've gotten so far. 15
20?
minutes.
Mm-hmm.
Another 15.
15.
It's really depressing, guys.
It's about right. It's
everybody.
about right, though. It's 20 minutes. That's really horrible. So you guessed it right.
I mean, none of us went into this to be in front of computers, right? We went into this to be in front of people. And there are larger things, right, that get in the way. Things like, like culture, right? How do you define the culture of a department and the culture of an institution? And again, I think COVID, if anything, has really just highlighted both the strengths and the weaknesses of our different institutions. And then finally, communication. And it can mean anything from communication, again, sort of the barriers that might exist between you and your patients and their families, but also just among staff, right? And getting to know people. And you don't get to really, I don't know, we didn't really get to enjoy those same social bonds that we would have done in non-COVID times. And I also think just again, like the events of the last year really highlighted the importance, both for good and for bad, of communication across the institution and from the leadership. Um, sort of down to us worker bees, as Rita says, and then back up the totem pole as well. I think one of the concepts that's important to think about as we start to move towards how do we have solutions, how do we how do we address all of these barriers, is to recognize that the interventions actually it's all the same, right? And so there are these drivers of both burnout and engagement, and they exist on a continuum. So when things are going really well, you end up with a lot of engagement, and when they're going poorly, you can end up with burnout. So communication is an example, right? And so if communication is going really well, both like sort of laterally and vertically, you get engagement from all of the healthcare providers and sort of all the people within the department or within the unit. But communication is going poorly, you're sort of at risk for burnout. And I think when we start to think about these interventions, it's sort of like, they're not sort of like, this intervention is going to help us and this intervention would hurt us. It's really all the same thing. And it's a matter of, are you doing it well in a way that fosters engagement, or are you doing it in a way that really, unfortunately, would promote more burnout?
Yeah, the Institute for Healthcare Improvement talks about that, Arlene. And in 2017, they wrote a very comprehensive uh, paper, a white paper, which looked at framework for improving joy in work. Just the sound of that is pretty cool, huh? Just having joy in work in the emergency department is almost novel, especially the way we're operating right now. So I think it's something we really need to take time to think about. And what the paper said, it really all starts with harnessing the power of leadership. And studies show time after time that strong leaders decreased the likelihood of burnout, and workers expressed all this satisfaction with their jobs and actually being well if their leader was strong, in charge, and had a really good understanding of organizational wellness. So they also found that physician well-being is an actual measurement of the organization's viability, and that the only way to really fight against burnout is to engage physicians, make sure they're engaged. So I don't know if any of you have heard about the 80-20 rule. Well, there's a study done, and what they found was that if, especially academic physicians, were allowed to pursue their passion a mere 20% of the time and be unimpeded in pursuing that passion, then the remainder 80% of the time, they were willing to do whatever their administrators wanted them to do. So that 20-80 rule is real important. If you don't get to do what you're really passionate about, then you're not going to be very happy. So the Institute for Health Care Improvement actually laid out 4 steps for every single organization in the United States, every emergency department, to maybe take a look at and see if they could improve their well-being. And the 4 steps are pretty simple. You get your group together, whoever you're going to interview and talk to, whether it's a group of attendings, a group of residents, the entire staff, and you're going to ask them what matters to you. And then after you find out all those good things, you want to find out what the impediments to joy are in work. And then you come up with a systems approach, and then you test those approaches. So let's go through all the steps one by one. we said the first step was to gather your group and listen and ask them, what matters to you? You know, ask people, what makes a good day in your emergency department? And I know I make a difference in the emergency department if I blank, blank, blank. Or what is the most meaningful part of your work? And when we are at our best, what does it look like? And not too hard. The important thing here is whoever is doing the listening has to do that. They've got to listen and not talk, because that's the important part about this. The second step is to figure out what the impediments are to joy in the workplace. Address those unique barriers in your specific locale. What gets in the way of a good day? What really frustrates you? Let me tell you what they did at the University of Michigan Cardiac Intensive Care Unit to do this, to sort of explore this. They had a discussion regarding joy in work to discover what mattered and what got in the way of joy in work. So they asked their nursing staff, their cardiology fellows, and all their scribes to sit down together and to identify the top priorities. This allowed everyone a chance to see the issues identified and to find out what to tackle first. So the next step, step number 3, is say, okay, we're going to make a system change. We're going to commit to a system approach where joy in work is really a shared responsibility at all levels of the organization. That's pretty amazing, isn't it? So, and it starts with, you guessed it, it starts with the leaders. And then there's sort of this trickle down effect where the senior leaders inspire those in the managing positions, and those managers inspire leaders at the lower levels who go on to inspire, not me, the worker bee, us in the trenches, or maybe our internal medicine colleagues on the floors in the hospital. So leaders lead the way so that everyone feels empowered to contribute to joy in work at the hospital, the clinic, the emergency department, whatever. And you know what? By doing this, this improves those metrics that the C-suite is always paying attention to. And one of those is patient safety. The improvement of the patient experience, the quality of care increases, staff satisfaction increases, and there's improvement in the system as a whole. So you ask me, well, how do you do this? Well, the American Association of Critical Care Nurses found that it was vital to have a constant wellness champion dedicated to joy in work. And this creates a sustainability and creates forward momentum, so you don't lose that. So the last step is going to be to use improvement science to test for joy in work. And let me give you an example that's close to home. It's at the University of Virginia School of Nursing. And they found that their employees during their time off really wanted to be unencumbered by the expectation of responding to emails. Can you imagine that? Wouldn't it be great not to have to answer emails during our time off? So they started with a very small sample of nurses, sort of like a pilot study, and tested this small change. They stopped sending emails to the staff during their time off, and the benefits were immediately evident. So they expanded it to the entire School of Nursing. And in a follow-up survey, after the change was implemented, 80% of respondents reported improvement in respect for their personal time. So you can see it's very obvious that improvement at the system level really impacted everyone's well-being at the personal level. And this is a favorite of Arlene's. She likes to talk about this.
Yeah, so in my day job, I'm an educator, and this comes up quite frequently, that it's like, oh, we have this great intervention, and it's like, well, if you gotta have some way of knowing if it actually had an effect, right? Did it do what you wanted it to do? Was it effective or not? And so there's a quote from this guy Peter Drucker, who's an American economist. He said, if you can't measure it, you can't improve it. and figuring out some way to quantify some of the efforts that we're doing is really important. It is difficult because wellness and well-being and joy, and it's like, how do you quantify such a nebulous concept when it means it means such a different thing to different people? I will say that there are some tools out there. There are some ways that people have tried to quantify this. Probably the best well-known is the Maslow burnout inventory, and we hear a lot about burnout these days. But that's really only one facet and one measure. And I think what Rita was talking about earlier is really important to recognize, and that if you use the MBI or burnout as your measure, that doesn't necessarily guarantee that the people that you're working with have joy, right? Because it is not a measurement of joy, it's a measurement of burnout. And certainly there are other scales that measure things like mood, that measure things like resilience, that measure things that are sort of peripheral to well-being that you might have. So like sleepiness, right? Like how well rested are you? There's a variety of other scales out there. And so essentially what I would encourage, and again, it doesn't have to be sort of this like very statistically externally validated sort of scale as well. There's many, many ways that you can measure improvement. Focus groups, sort of internal surveys, one-on-one interviews, those types of things can be really powerful in measuring it. But again, this is a really critical thing. And I think historically we're not as good about doing it for wellness interventions as we are with other types of quote research or other types of like sepsis or like, door to whatever time. Like we're very good about those kind of numbers, but we're not nearly as good about wellness. But I would argue that this is, if we think that this is as equally important of an operational measure, then we should be treating it as such.
Totally agree. And COVID uncovered something that we haven't measured, and that's moral injury. That's what this slide is all about. So take a look at the soldiers in the picture to remind you of moral injury. The moral injury we experience is similar to the trauma experienced by these soldiers in battle who just arm themselves psychologically and try not to think about the carnage and death that surrounds them. They have to go kill, even though they might not want to do it. So to do our job, and we do our job, we not only dress in PPE, but we really shield ourselves with this protective emotional barrier so we can carry on in times of extreme stress. And this became particularly obvious during the surges of COVID. And Arlene knows, she was in New York when this happened. And we just saw things come apart. We saw physicians, emergency physicians, die by suicide. And I wonder, could that have happened to you or me? So I ask you, what are we waiting for? Almost half of us suffer from burnout, and even more are at risk. And we continue to wear our protective emotional armor in order to care for patients. And we may not process the misery surrounding us until we have downtime. And that is where the danger is, that downtime. So comparable to soldiers in war, we know that as soon as we stop doing, we're going to start feeling, and we have to be ready for that. But remember, this, heroes don't cry. Emergency physicians have learned that vulnerability, saying, I need help, is really yoked to shame, not courage. Physicians would rather die than submit to the trauma of admitting helplessness or weakness. We can't say that. And you know what? There's no space in our organizations either to be vulnerable. The system sets us up, so it's difficult to talk about anything.
It's interesting, Rita. So William Binder and I have been having this little side conversation during our talk, but it is, I'm bringing it up now actually, because I think it highlights what you just said, and that one of the fundamental problems, I think, with addressing this on a systems level is exactly that. There is a hidden message or a hidden curriculum in the House of Medicine that says that doctors don't show weakness, heroes don't cry. And I think that understanding, that pervasiveness in some ways is what's getting in the way of all, because it's viewed as something that, oh, but we don't need it, right? Because we're supposed to be strong, and this is like wellness is a nice extra or like a nice perk, instead of sort of fundamental to the ability for us to do our jobs, right? And I think in many ways we are at the nascent stages of trying to make this. It feels like we've been talking about it forever. It feels like we've been talking about systems change forever. You know, again, like sort of leaders in the field, like Tate Shanafelt, other leaders, Colin West have written extensively, like, we need systems change, we need operations change. This is a huge problem. This is like a, you know, an epidemic, another pandemic. But again, it just still feels like we're at the novice level. And I think because it represents what we need is a fundamental change in this attitude of what it means to be a physician. Again, Shanafelt does do a nice job of putting together this framework of what it would look like in a really sort of hypothetical perfect world, as organizations sort of make this journey from novice to expert, and then consequently the, you know, sort of the interventions that they put forth have a correspondingly minor to transformative impact on each and every one of the individuals within the institution. At the very, you know, sort of off the screen is zero awareness, which sadly I think there are some places that are there. But at the very lowest levels, right, at the novice stage, you know, these are institutions that have some awareness that this is a problem, right? So these are places that have recognized that, yes, well-being is important. Yes, joy in work is important. They may have some sort of introductory type of things that have got, like starting a wellness committee, whether that's within the department or within the institution. They may be putting out resources to their employees, being like, hey, here's like an app that we recommend on meditation, or, you know, here are some tips on how to do easy yoga poses at home, right? This is at the very mumuch at the novice level. I know, Rita, I see your face.
Or here, let's let you meditate. Here's a meditation app.
Yes, or wellness on wheels, right? And so having a, yes, remember the wow wellness on wheels. That's at the novice level, which, to be fair, is one step in the right direction. Next up, though, you know, you have organizations that are doing a little bit better. So these organizations understand that driver concept, that intervention sort of can be used for good or for ill, right? It's the same levers that you pull, whether they head towards engagement or whether they head towards burnout. And these are interventions that start a little bit deeper within these types of organizations. So you start to see things like peer support programs, where they're sort of cross-institutional or sort of within each of the departments. You start finding some systematic ways that individual units are trying to assess the problem. Again, whether that is sort of like incident reporting or focus groups or departmental meetings. Across the institution, they've started to identify which areas in particular are struggling, although may not have any particular solutions yet. And people at the C-suite are starting to talk about it. But it's not till you get to the next level, to the competence stage, where organizations really understand the business case to promote physician well-being and start to put their money where the mouth is, right? So this is where you start to see money being put into some of these interventions, where you start to have operational redesign that is based on these things, and where people in these individual work units are really given voice to their concerns, and they see that things are being actioned upon. And again, this is also sort of where it's interesting. It's also where the interventions start to make this transformation from, quote, classic wellness looking, like things stop looking so much like wellness interventions, and they start increasingly looking more like operational interventions. But again, these are sort of work unit redesigns. These are people being given voice into systems issues and how to improve operational flow, and thus, sort of their work experience when they're at work. And additionally, you'll see some money being thrown into supporting activities that allow for community building. At the proficient stage, you have organizations that understand the impact of physician well-being on key organizational objectives that might include things like finances, turnover, patient safety and quality, and patient satisfaction. Well-being starts to be considered in all operational decisions. And again, you're noticing this shift that things are becoming increasingly more operational. Start to find interventions that reduce clerical burden. You start to get training for leadership and participatory management and more systems level sort of interventions and measurements. And finally, when you get to the expert level, eventually, maybe, well-being is sort of not just being understood that it impacts key operational decisions, but that it is important to include in sort of like the mission statement, or like sort of what the institution is about. There, you find things like a chief wellness officer. You start getting things like endowed programs, and then the end goal for all of this is really to create this culture of wellness that does not just view wellness as like a nice perk, but really something integral to the practice of medicine and ultimately patient care.
Yeah. Arlene, question for you. Where do you think most departments or institutions are now? If you had to say, what would you say?
I don't know that COVID has changed where they are per se,
Mm,
but maybe just sort of laid bare um,
yeah.
where people have been. And honestly, I think I think good institutions they're doing well if they're at the beginner stage.
Yeah.
I think most
Yeah.
are probably at the novice. I don't think there are any institutions that really have no awareness, but we're really sort of looking at that bottom left-hand corner of the screen.
So it sounds like we have a long way to go. Long
Yeah,
way to go.
fight the good
So,
fight.
yeah, we're going to fight the good fight. Now we're going to go back to aluminum foil and Alcoa and the 3 daily questions. And I'd like to suggest that rather than using these 3 questions as a specific measurement tool, I'd like you to take a look more globally and ask what would it look like if we could answer yes to each of these questions? So your job after this talk today is to approach your department or your system with a true understanding of organizational wellness and resilience. And it needs to be all of us that are promoting interventions that address the underlying operational issues that lead to unwellness in the first place. And we really need to find solutions that benefit everyone, the the clinicians and the patients. And we need to change the healthcare system that we work in. Together, COVID or not, we can make this happen. What we'd like to do right now is to see if there's any questions in the chat box. And Taylor, do you see any?
Don't appear to be any new questions in the chat box right now.
That's
Sorry, I
okay.
think it was just my monologue. My monologue.
No,
of
no,
just,
no, no. I have questions for our participants, and that is, what do you see? Can you identify, and you don't have to identify where you're from, but what have you seen are good wellness processes at your institution? Just to give other people in this, and you don't have to put it in the chat box, you can say it out loud. What are other people doing? Or what, and conversely, what are other people having trouble with? So you can do both.
I'll give people some time to think, and I'll actually highlight something that came out
Yeah.
during COVID. Again, I'm super grateful for my institution and my department. I think even before COVID and through this past year, but I think one of the things they did really well was communication. I think hands down, communication was like the best wellness intervention that our leadership did. And I think, so like I said, in my day job, I'm the program director, so I sort of sit between the residents and our departmental administration. And I think the whole time, just our residents feeling like they knew what was going on, even if they maybe couldn't affect a whole lot of things. Like we didn't know what we were doing, we didn't know this, but they just felt like some measure of control because they felt like our leadership heard them, that they were listening, that they were available, and I think that went a long way towards their well-being. Much more. I mean, they got like free Puma shoes and they got like Patagonia stuff, and it was just amazing. But that stuff aside, I think really the communication piece was really critical.
How about anybody that's participating? What have you guys seen? What are they doing out in Denver? What are they doing in other parts of the country? Has anybody seen any? I mean, even if it's a little thing, even if it's an ice cream social for the residents, that happens a lot on the East Coast. So,
Yeah, I was going to ask you a question, if you don't mind. I mean, while people are thinking about it, what would you say if I said you have 3 interventions, let's call it top 3 interventions that a department, at emergency medicine department level, can do? And I think, Arlene, you articulated one: communication. Although communication can be many things, so I'm not 100% sure that I understand what is the magic communication. Is it all forms? Is there a particular one that worked better But what are the top three things? If you had the ticket to go to your chair and say, here are the three things, no matter what it costs, this is what I want you to do, what would they be?
Well, I can think of one right away. And that we had said that it really depends on leadership. So depending on your leader, if you have a really strong leader, somebody who understands that wellness does start at the organizational level, then I would say you can keep that leader there. If you found that leader really didn't have a good understanding, then what might be the next smart move would be not yoga or meditation, but it would be to maybe have what's called a 360-degree evaluation, where clinicians evaluate leadership, and usually how leadership evaluates us. So instead of it only being a one-way street, both groups would be evaluating each other, and that would be a way to make awareness, because when you have those evaluations, the people in the trenches sort of let the leaders know what's going on. So that's more of that's up near the top of the graph, the expert level, because just having more socials and doing things like that is not going to make a difference. Arlene, what about you?
I don't know. I like frameworks. I don't know. I really enjoyed psychology when I was in undergrad. I put it in the chat a little bit earlier. There is a model of there's many models that exist, but there is a model of professional fulfillment that exists by these two psychologists, Ryan and Deci, and then they say that professional fulfillment is really a combination of three things: it's autonomy, competence, and social relatedness. And I think interventions that specifically address those things. So I think there is some role for ice cream socials. Like I think there's a reason people are drawn to that, to retreats, to we put a picnic bench outside during COVID so people could sit outside and have their lunch rather than just in the break room. Like just get outside with some sunshine in the summer and in the spring. I think that kind of stuff is important. The autonomy piece, I think, David, to your point, plays into the communication, and I think people like to feel like they have agency and they have control over sort of their jobs and what they're doing, and that they have a voice in key decision making. And I think any mechanism that you can do to improve that, whether they are town halls, whether it is quote fireside chats, whether it's like question boxes, things like that. And again, we did that during COVID. We had town halls actually across the institution where any employee could send a comment or a question to an email address, and they would literally go line by line and they addressed every single one during each of these weekly town halls. But I think people feeling like they have some kind of voice in the decision-making process that's going on. And then finally, competence, right? We all want to feel like we're able to do our jobs, whatever that means. So having the equipment that we need to do it, having the space, having the time, the resources, the support, the ancillary staff to actually be able to do our jobs is important. So I think, I don't know, like I said, I like frameworks. I think they make things easy to understand. So I would say, like, if you can, I think aligning some interventions along those three pathways makes a lot of sense.
Yeah, and I think the third step would be you've got to educate everyone so that they don't, so they're not thinking that it's their own individual responsibility for their own wellness, because that's what a lot of people think. People think, well, as if I really get my own wellness together, I can go into the emergency department and I can feel well when I come home. And that's not how it works. If you go in and you're 100% pumped and you're just in a toxic environment, when you come out, you're not going to be pumped like you were when you went in. So there's also another question is, how would you approach a chair at an unwell institution to reverse the trend? Do you want to tackle that first, Arlene?
Depends on where your chair stands in this, right? I think you approach that conversation very differently. Is your chair part of the problem? Or is your chair part of the solution, right? This is change management. Are they a supporter or are they not a supporter? And I think maybe you approach those questions differently. I mean, hopefully your chair aligns, and I think everyone I think it's always better to come to someone with solutions rather than problems. And even if you don't know if these solutions are right, just coming with some suggested things. Hopefully you take some concrete ideas away from this talk, right, that you could use to approach your chair. If your chair is not sympathetic, I would suggest finding people that are higher than him or her who are.
Exactly. I think Arlene brought up a really good point, and that is solutions. And so what you can do is go to ihi.org, ihi.org, and look at that framework for improving joy in work, and look at those 4 steps and bring those 4 steps to your leaders and say, here, these are the things we can do. I will volunteer to get your first focus group together, something like that. And I'd just like you to come and listen. And that might be a way to approach it. So we are at the top of the hour, unless anyone has, we probably have time, a minute for one last comment. Anybody have anything to say? Kristen, go ahead.
Well, so we have this thing called an administrator on call. It's a pretty new thing, but it's one of our admin team who is on call every single day, and they are physically stationed in the emergency department or nearby, and they expect to be called. And this has taken a little bit of a culture change because, we don't usually call in for sort of backup, but it's backup for administrative problems, which is, when you talk about what makes joy in my shift is getting to take care of my patients smoothly, right? Not running up to big consultant hassles or some sort of other logistic nightmare that I get stuck in, and now I can't take care of the other patients, right? So that's what the AOC is for. If I'm getting really a lot of, if it's I don't want this patient on my service and I don't want this patient on my service, and you're playing this which services this patient belong on game, then you call them and they play the which patient does which services patient belong on game, and they take you out of the loop so you can continue to see the rest of your patients. That has been very helpful. That is part of the joy in my life, is not having to deal with that fight.
That sounds really great. We can only hope that we have some of those kinds of changes at all of our institutions. So with that being said, I'd like to thank everyone for participating today. And we feel free to contact us at any time. Arlene?
I just want to say, keep going out there, fight the good fight. Enjoy the rest of the conference, and feel free to reach out to Rita or I if you have any other questions or didn't quite catch a resource that we shared earlier during the presentation.
Take care, everyone. Enjoy SAM.
Thank you for coming.
Bye.